Welcome back to another episode of the Pharmacist Diaries podcast. Today I am really excited to spend an hour with an incredible specialty registrar in infectious diseases and microbiology, and her name is Grace Barnes. Now, we don't traditionally have non-pharmacists on this podcast, but for this week I'm really excited because it is World Antimicrobial Resistance Awareness Week. And part of the aim of these conversations is to share with you what different healthcare professionals do in the journey of antimicrobials, how they manage antimicrobial stewardship, how do we deal with antibiotic-resistant infections, and a whole lot more. And I've been working with Grace for the last few months now, and we have developed an amazing friendship. And this is an opportunity, A, for me to get to know her, but also for me to share why she does what she does and why she's passionate. And the other thing that I really want to get across in this conversation is the importance of collaboration and working with other healthcare professionals within this field. So let's introduce Grace to the podcast. Hi, Grace.
Hello.
I'm so glad to have you here, actually.
Thank you very much for inviting me. I feel hugely privileged to be a non-pharmacist and on here. So thank you so much for asking.
Honorary member of the pharmacy team.
I'm so proud.
I'm so happy to be here with you, actually. And I'm really looking forward to getting to know you. We've learnt a few things about each other over our lunch periods.
We have.
Especially international working and kind of the global health chats that we've had and things that we want to do on an international scale. But I'm really interested in your journey as a doctor and why you kind of followed this field in terms of medicine and why you chose microbiology. So tell us a little bit about that journey from back when you were in A-levels and you were making decisions about university.
Yeah, so it feels like only yesterday, although it's probably quite a while ago now. So in school, I always really liked science and found it really interesting and knew that that was kind of always what I wanted, something within science, and also really like people and working in teams and chatting. I can chat away for hours and wanted a combination between science and kind of chatting and a people-facing kind of role. So I knew it was something in the public sector and did a few taster days, did some work experience, and then kind of fell in love with medicine, really. So I think I knew from 16 that was what I wanted to do. So I applied to various medical schools and got in. I was fortunate. So I came to Oxford and studied medicine there and felt a bit like I was in Hogwarts when I first arrived. It was very different to my South Wales Valley that I grew up in. And so studied in Oxford, and that is a 6-year course. So I did medicine for 6 years. 5 of those years were based on medical school and learning the medicine. And then they give you one of the years you can do a little bit more kind of research-based science type degree. So I did an additional degree, an intercalated degree in the middle in medical sciences. And I think that's where my kind of interest and passion for microbiology started. So I would have been 20 when I started that. And I joined a research lab in Oxford, and it was a brilliant team, Professor Tang in the Sir William Dunn School of Pathology. And I worked with him for a few weeks, and it gives kind of medical students and undergraduate scientists a chance to do a research project, start to do a little bit and learn about science alongside the kind of medicine practical aspect. So I did a project in microbiology quite generally, and it was vaguely related to meningitis and Neisseria meningitidis. And I loved it. From that stage, I was always fascinated with the kind of intricacies of microbiology and how it all works together and how these bacteria can invade things and cause problems, how we can treat them. So that's where the passion started. And then I came back into medical school, finished and graduated as a doctor. And then since then, every job I've done, I've always enjoyed managing patients with infections, talking to the microbiology team and the ID teams. So I thought, this is a job for me. I found my people, everyone I spoke to, I loved everyone within the team, and the wider infection team is always huge. And I really liked that aspect as well. I could work with pharmacists, could work with support workers, the nurses. It was so many people, and everyone has such an interesting story that I never really looked back. So that's why I applied to come and do infection.
Awesome. And during your university years, you also got to travel as part of your electives. What was that like?
It was really fun. So you get kind of a 6-week, or it varies really in medical schools, how long. We get a period of time after you've finished your studies, and usually after your final exams, and you get a bit of a holiday to kind of go away for a bit, and then you come back and you go an elective. So you pick somewhere in the world, or can be in the UK, going into an area of interest. So I went to Australia in Melbourne to do infectious disease, which was incredible. I was there for a month working with the infectious disease team, got to see all sorts and different patients, different populations, And that was the first time it kind of really opened my eyes to the thought about global health. And actually, infection is very different in different places. There are different challenges here, different bugs, different antibiotics that we're using. So, for example, I didn't see anyone use Coamoxiclav. And I was like, why are they not using this antibiotic that everybody uses here? And so that was really insightful for me. And that's where my kind of love of thinking about travel and global medicine and global health and global infection started. And I also did a month in Hong Kong as well, which was also really interesting on my way back. So I stayed for a month and I was based with the pediatrics department in Hong Kong and did some pediatrics infectious disease as well. And that was, again, really interesting to see patients and these children and how they were treated. And it was just so different to my experiences in the UK, where I'd done some UK-based PEDS ID, that I found it really, really interesting and informative. And yeah, it continued to inspire my passion to pick microbiology.
I mean, I'm just curious, slightly off-topic question, but when you worked abroad and having seen what the healthcare systems are like and making a comparison now to working in the NHS, like, were there any specific differences that you saw that were interesting, or things that you might have seen that you brought back to your practice here?
Yeah, it's a really interesting kind of thought about it. And when I was reflecting on what I'd done and seen in Hong Kong, it was more... There was like the lead consultant, you would follow the consultant around on the ward round, whereas in kind of Australia, it was a little bit more of a kind of collaborative approach, and there was like lots of the team members involved. In Australia, there was more of an MDT setup, whereas in Hong Kong, it was kind of the consultants that would lead the care. And there were kind of pharmacists and nurses and everyone else was kind of part of the team there, but it just was a little bit different. And I quite liked the collaborative approach that I saw in Australia. And then again, in Hong Kong, it made me think a bit about... They had kind of Western medicine and then the traditional medicine, and it was integrating those thoughts as well. And that's something I'd not really thought about, being based in the UK and training here. So it made me a bit more aware when I'm talking to people who may have travelled or not grown up in the UK originally, to ask a little bit more about their healthcare settings that they're used to, and making sure that I can kind of adapt to suit them, or think a bit about what's different and why a UK system might be a bit unfamiliar to them, and trying to explain a bit more about what I'm doing and why we're doing certain things.
Yeah, awesome. I mean, having grown up in the UK, and whether you've seen a GP or been a patient as part of the NHS, you kind of know what to expect.
Yeah.
And when you step outside of that, there's a lot of variety. I mean, I talk a lot about my international experience working in Abu Dhabi, and there it's very much a case of the consultants are the ones driving what they prescribe, how they prescribe it, and that collaborative approach is still a massive learning curve. So even though you are quite an experienced pharmacist and you've got a lot of knowledge and expertise, a lot of the time it's that the consultant takes ownership for what they prescribe, and you can have a bit of a debate, but it usually ends with them.
Yeah.
and that is also the difference between sort of the National Health Service and private care as well. There wasn't necessarily a lot of national guidance in the country. So when you are prescribing in clinics, depending on what type of insurance you have, it also guides the type of medications that you use. So it's just interesting to see how different it is. But it did make me very grateful for the NHS and how established our kind of collaborative MDT style working is, and how well we work together. And we have a long way to go. There's so many things that I think are problems that we face, especially communication between different sectors of healthcare, whether you're in hospital going back to a GP, or you're in primary care coming into the hospital. That communication link still needs quite a lot of work, whether you're looking at like the different formularies and things like that, wherever you live. You know, there are differences as well. But I just think from the actual establishment of a pharmacist's role and how much we can achieve, and the fact that we're prescribing as well, you can see that we're far ahead of some other countries. Australia is quite similar to the UK, actually, in the way that they work, especially with pharmacy. They've only just started implementing some GP practice roles as well, which we've obviously expanded that for quite a few number of years now. So it's just exciting to see what your kind of thoughts were and how it changed how you felt about the role that you were going into. Tell me a little bit about when you become a qualified doctor and you kind of go through your foundation training, you become an SHO, in order to do infectious diseases and microbiology, what's the pathway?
So you start off, when everyone finishes medical school, you join a foundation training program, and that's a 2-year program where you rotate through various specialties of medicine, surgery, might do some general practice, might do psychiatry, and those are designed to give you quite a good grounding. So you do a little bit of everything, experience a bit of all kind of different specialties, or a variety of specialties rather. And then at the end of your foundation training, most people have a bit of an idea about what they like. So if they've worked in A&E, they might decide that I love that. Actually, if equally someone might do it and think this is not for me, I actually prefer an inpatient ward. So I did 2 years of that. So I did my first year in Oxford and my second year in Stoke Mandeville, and did my training. And over that, I was exposed to different types of specialties and jobs. Then if you're interested in infection, so I knew that was what I wanted to do, you then start an internal medicine training program. So that is when you're an SHO, you do 2 or 3 years of additional kind of medical training. It used to be core medicine training, it's now internal medicine training, but it's similar in that you rotate around different medical specialties this time. So you don't do kind of GP or A&E, these are inpatient medical jobs. And you work through these as well as you go, building up skills and expanding your ability to work as a doctor, and you develop your independent thinking and your ability to make decisions and managing complexity. And you kind of, looking back, you see how much you've grown and changed from F1, where I didn't know, I'd be really scared about everything and asking every question to my registrars, to the point where I was the registrar. I was like, actually, I know how to manage this, and, I know what we're going to do here, and guiding my juniors and the people I was lucky enough to work alongside as a team. So you do your internal medicine. You can do 2 years of internal medicine and then do infection and microbiology. You can do 3 years of internal medicine and then do infection paired with general medicine. So you do an extra year to work as a med reg. I actually combined both of them. So I did an extra year to work as a medical registrar to get extra experience. And then I applied to infection and microbiology training. So I did kind of a bonus year of general medicine because I quite enjoyed it and thought, again, it would quite help me when I start my infection jobs to think a bit about the patient in front of me, because everyone presents with all sorts of different things.
Yeah, I mean, a recurring theme in this entire series is that microbiology or working in antimicrobials, you still have to be a really good generalist.
Yeah.
You have to understand the patient from a holistic point of view, but you also need to understand all the different types of medical conditions, all the different surgeries, the complexity of the patients, as well as you're looking at polypharmacy. So I think it's really good that you took on that extra year, because it gives you that general foundation before you then niche down.
Yeah.
Awesome. I love that. That's awesome.
It was really fun.
And now that you've gone into your kind of specialty registrar training and within microbiology and ID, what's the typical day in the life like for you?
So I'm currently on a microbiology block in my current hospital here. So I will go in the morning and have, say, the blood cultures that have flagged overnight. So any positive blood cultures patients have when they come in, they might get sent if they've got a fever. The medical teams admitting will send them off to our lab. We will grow them in the lab. And then when those flag positive, the machine kind of reads them and tells us in a really clever way if something is growing. It's then us working with the biomedical scientists in the lab to have a look down the microscope physically at the blood. What can we see? Are there any organisms in there? And deciding what it is. And then based on that, what it's likely to be and what we're going to treat the patient with. So my day starts looking through those. And then anything that's positive, I will speak to the team looking after the patient and try and get a bit more information and use that information along with the kind of lab bench information to work out this is probably going to be an E. coli or a Staph aureus, and give advice on antibiotics to start. And then throughout the day, we get a bit more information, and over the coming days, each blood culture, we do a little bit more work until we can definitely say, this is the organism, these are the antibiotics we can treat it with. And throughout that time, I'll touch base with the medical teams to say, how's the patient getting on? If they're not well, maybe we change to this antibiotic, maybe we narrow down to this one instead, if it's very sensitive, and give a plan about duration. Hopefully, a microbiologist is helpful in terms of suggesting investigations as well. Sometimes we get certain bugs that are we know that live in the mouth or are related to the gut. And if we grow one of those, we might suggest to the team, have you thought about imaging? Have you looked for a dental infection? It helps us to kind of guide their treatment because they're very busy and have got lots and lots of patients. And if we can give a little bit more support and guidance on the specific kind of minutiae of microbiology when we've grown up a certain bug, hopefully that helps. And then otherwise, we also work with multidisciplinary teams for different specialties. So I might go and talk with the haematology team or the spinal team. Work with the lab team if they get a result. We kind of work together to work out, is that significant? Do we need to do any additional tests on it? and then provide like a consult service. So someone can call up if, a medical team wants to ask for advice. They can give us a ring and say, this is the patient. Have you got any thoughts about what we should look for, what we should test for, what we should treat with?
And have you noticed any differences between, obviously you're working in a district general at the moment and you've come from a big teaching hospital. Have you noticed any differences in the way that the teams work, or kind of the role or the specialist area? How do they differ, or how are they similar?
Yeah, so I guess in the district general hospital, the general teams manage a bit more, not more, they have kind of the same patient volume, but they might have a more varied workload. So someone with endocarditis, which is an infection of the heart valve, they might present and be under the medical team initially, rather than in a big teaching hospital, they might go straight to the cardiology team. So you have more kind of general cases. The presentation is quite similar. I've seen loads of different types of infection and presentations coming through, and I think the population that you serve within your hospital is the main guider of that. So it depends kind of if we're in a rural area, if we're in a big city, if it's somewhere where there's lots of travel, you're going to get more fevers and travellers and cases of malaria and dengue, that sort of thing. So that's a little bit different. But otherwise, the kind of day-to-day management is the same. Just in the bigger hospitals, there are more people. So you have an individual team for a certain part of the hospital, whereas here, the micro team cover everything, all of the sites, and try and kind of give advice to everyone that they can, but kind of limits you and you can't go and see everybody. You have to kind of give advice over the phone and then go and see the ones you need to go and see.
Yeah. And obviously we attend ward rounds together, whether that's ICU, the C. diff ward rounds, we go to spinal, and we go to trauma and orthopedics, our favourite place. And on Wednesdays, you also have teaching. So part of your journey, even though you're working, is that you're still getting that continual professional development. Yeah. What types of things do you learn in your kind of Wednesday sessions?
It's all sorts. So we have quite a broad curriculum that's kind of set by the national standards for all of the trainees across the country in microbiology and infection. We all cover the same things. So we have this curriculum to guide us and make sure we all have vaguely the same knowledge. So it can vary, and it's done by one of the specialists. So we have teaching from the antimicrobial pharmacy team. Mike taught us a few weeks ago, thinking about management of patients with a splenectomy. We might have teaching with one of the consultants in infection. So we've had teaching sessions on management of TB and thinking about that. So it's varied and covers all sorts of infection. Within that, we also might think about infection prevention and control. So it's kind of different aspects of microbiology, and still as important, but thinking a bit more about the public health and whether we need to, looking at if there's an outbreak or an infection somewhere, how do we look into that? How do we help? Because that's kind of the other part of a microbiologist's job that isn't as obvious and isn't directly facing patient care, but something that's equally as important for kind of population health and public health.
Awesome. I think your role is sort of like you're the link between the clinical team and the lab, which is really cool.
Yeah.
But you are a doctor.
Yeah.
So it's really cool, actually. It's really interesting because I never thought about this before, because when you think about microbiology as a term, you kind of think about labs and scientists, but actually you are a medical doctor, but has chosen a specialty which is in between the clinical team and working in a laboratory and kind of collaborating those two things together. So when you're looking at kind of resistant infections, maybe you could share an example of something that you might have seen with regards to a drug-resistant infection, and how your expertise, your knowledge, and things that you've discovered through lab results has actually changed the treatment for a patient. Yeah, so
there's a kind of increasing prevalence now of antimicrobial resistance, and it's something that we're all thinking about and aware of. Over the last few weeks and months, we've had patients with resistant infections, and sometimes that can present with an infection, a patient who is unwell. We grow, say, from a blood culture, we get a bug, and say that bug is an E. coli, which is quite common, not, a bug that we can find in the blood. That initially we might treat with one type of antibiotic that's kind of broad spectrum, something like coamoxiclav or even amoxicillin and gentamicin. But actually, the link that I think is helpful is when you're talking to the clinical teams and seeing how they're getting on, if that patient's not improving. And so there's been examples where someone was started on an antibiotic, they weren't really responding, still spiking temperatures, still clinically unwell. and the medical team were worried about them, at that point you think, hang on, is there a resistance here? Is this bug actually not responding because we're not using the right antibiotic and we need to use something a bit broader or use a different class of antibiotics to try and kind of work around any resistance mechanisms that an organism might have? And then you would go back to the lab and have a look at the bug that we've grown in the lab, see what we've tested it against in terms of antibiotics, and then we can work with the scientists in the lab to say, can we actually test for this antibiotic instead? And that helps us to then open up a few more options that we can go back to the clinical team with and say, okay, stop that antibiotic, please switch and try this one instead. We think this is a resistant organism and we need to slightly change our treatment here. And so, yeah, I've had examples of E. coli, as they say, in blood that was resistant, and when switching to something broad spectrum in a different class, like a carbapenem, that has treated something that was a beta-lactamase inhibitor, so resistant to penicillins, which were used as the kind of first-line treatment for the patient. So in switching, the patient then got better, which is what we all want, and then we're able to kind of treat this infection, get the infection marker settled, and clinically they responded and got better.
Awesome. And from a collaboration point of view and multidisciplinary working, you get to work with us, pharmacy legends. And you get to work with Claire, which is awesome because she's such an established and experienced antimicrobial pharmacist.
Yeah.
When it comes to that collaboration with regards to antimicrobial stewardship, like what are the bonuses of having a pharmacist in your team, and what examples maybe do you have where you have collaborated together, had an amazing discussion and figured out solutions for a patient?
So I think it's so important to have this multi-team approach. And I absolutely love working with you and with Claire and with our pharmacy team for that reason, because we think about slightly different things just because of by virtue of our background. If I've come from like a clinical perspective, thinking about the patient, and the kind of pharmacist on the team might be thinking about the drugs that we're using, I think it's so useful to think about what our options are in terms of bioavailability. Can we switch from an intravenous treatment to an oral treatment here? Or broad spectrum, can we narrow down actually if we've got an organism and an explanation, why are we treating with something broad when we could use something a bit more narrower, thinking about antimicrobial resistance in the background of that. So for example, Claire and I were fortunate enough to work with her, and we went to go and review someone on the ward that had quite a resistant organism, kind of a soft tissue infection with that organism. And in seeing the patient together, we were able to explain what was going on, what our plan was for treatment, and also explain to the patient the side effect of the antibiotics and how this would be given and what duration it was. And working with the patient and with each other, we realised, the patient was having, when it's going intravenously, there's certain side effects they were experiencing, and it's thinking, okay, how can we get around that? Could we use like a longer line to give it? Actually, is there an oral treatment we could use instead? Do we need to change the frequency of the dosing here? And so it worked really, really well, and we were able to work together to come up with a plan, and the patient was treated and has been treated for their infection, and it was quite a kind of long course of antibiotics we had to use, so we wanted to make sure we got it right. And I think it's so valuable working as part of a team. I definitely couldn't have done that on my own and wouldn't have known what to have done, and it's only through working with brilliant pharmacists that you get that extra input for a team, and then the patient gets the best care, which is again the most important thing.
Yeah, it's so nice because working with pharmacists, you've got that expertise on pharmacokinetics, side effects, interactions. I mean, recently I've asked for drug charts to be brought into MDTs because I feel blind when we're just naming medications in discussion. But when you look at pharmacy from a very holistic point of view, we want to look at polypharmacy, we want to check for interactions, we're thinking about contraindications. We want to make sure levels are done. We're looking at the renal function. All of those things are things that you need to do, and you're thinking about it. But actually, you get to focus on the expertise that you've got, and we get to focus on what we know, and then we just bring it together, and it's just like magic.
It is. It really is. Yeah, because it's stuff that I just wouldn't think of, or it would be in my mind, but it's lower down my list, and it's just... Actually, now I think I can suggest something and you will jump in and be like, that's a silly idea, or maybe we look at their renal function before we prescribe that. And I think it's so important working together. Yeah. It definitely is.
I think one of the things with working as an MDT, which we spend a lot of time, and I guess from an efficiency point of view, we spend a lot of time sometimes in rooms where we've got a drug chart, we've got knowledge about the bugs, the antibiotics that we're using, the other medications, the other medical conditions. But I'd really like to see us approach ward rounds at the patient bedside. And even though we do that on ICU once a week, you're in an environment where the patient might not actually really be able to respond. So when it comes to ward rounds in other areas such as spinal or trauma and orthopedics, it would be amazing to actually do the round where you can interact with the patient and make a kind of shared care decision with them, because you make the decisions on behalf of the patient and you've got their best interests at heart. But actually, it's really valuable to hear their opinion, see what they want to do, or see what kind of medications they want to take, or is that going to impact their routine? Or even with children, I mean, I work in pediatrics, it's really valuable to have the parent around, whether it's to do with adherence or do they take capsules versus, only really taking liquids, because so many children will only take liquids, mixing crushed tablets with food. How do you manage school routine? Like antibiotics and school routines are so hard, or like nurseries. Even the logistics of something as simple as giving them 2 bottles, one that's kept at home in the fridge and one that's kept at nursery in the fridge, was something that I discovered during my work at Evelina, because we were giving out a lot of antibiotics and we had a policy in place that allowed us to give a slightly like an extra supply.
Yeah.
Because to keep taking it in and out of the fridge and traveling to and from home and nursery, sometimes parents would forget the medication in the fridge at nursery and then they'd miss doses, and all of that would impact. You've also got to make sure that schools have nurses available or staff available to actually administer medications, and whether or not they're willing to support you on that journey, because some parents do have struggles with that as well. So it's just really interesting to kind of see where we're at now. And sometimes conversations like this make you reflect and think about what we can do to sort of improve what we're working on. I also wanted to ask you about, the future, and looking ahead, what's really exciting for you in the world of microbiology, and also in terms of your career. What are you excited about doing as you go through this registrar training and your plans for consultant work?
That feels like ages away, but it's going to come soon enough. So I think I'm kind of a first-year registrar in microbiology and infection now. So I've got the kind of whole training program ahead of me, which is really exciting about all of the possible options. And I think for me, one of the key things I'd love to do is a little bit of extra work on global health. I think that's where I first started getting passionate about it. And when I travelled to Australia, and that's kind of really ignited the passion. So I think going forward, I would love to do it some extra kind of time to get a bit more information and experience with global health and working on a global level. And I think just generally in training in microbiology and infection, there are so many opportunities available to us with collaborative working with different teams and coming up with new ideas and research projects and kind of getting those going and off the ground. I think there are also challenges to be aware of within microbiology that are going to pose kind of an area that we have to focus on. So antimicrobial resistance being a kind of really big one, and thinking about how can we narrow our antibiotic choices? Can we work with educating kind of teams about these are the antibiotics we're choosing and why, and the duration? I think climate change is going to be a big thing as well, thinking about that and how we can influence kind of the NHS carbon footprint. Maybe if we can find a good oral option that we can switch to, that's going to use much less in the way of packaging and intravenous drips and plastic than using intravenous antibiotic therapy if it's appropriate for the patient. And I think travel as well. The world's quite a small place now. We can travel all over the place. And as people travel, there is risk of infections and different organisms moving, and just being aware of that and constantly learning. I'm just excited to learn. There's so much to learn. And every day I do something new or I see something exciting. I'm like, oh, I didn't know that. I'm going to read about that now. And that's what really excites me going forward, I think.
I love that. And I'm excited for you.
Thanks.
This is really cool. And we get to work together, which is really cool.
We do.
When you look at the role of a registrar, I mean, you've explained so many things that you do, but alongside the day-to-day work that involves the patients, and I know at this trust, we are struggling in terms of resource for consultants. So you're more than likely being needed to step up a little bit in terms of the work that you're doing. But what other things do you get involved with regards to projects in the background? So pharmacists, we do our day-to-day job. We're on the wards, we're clinically screening prescriptions, we're processing TTOs, we're doing drug histories on patients, all of the kind of standard things. But in the background, we also do a lot of desk work, whether that's working on the formulary, understanding what supplies that we've got, looking at finances, updating guidelines. That's a massive part of the role in antimicrobials as well. and we have a lot of kind of leadership opportunities and projects. What other things do you kind of have access to or get involved with from that point of view?
So I think in the day-to-day work, I help with the clinical work. And as you say, there's consultants around to help me with that side of it. But outside of that, I help with maybe talking to the infection prevention and control team, seeing if I can help with something there. Sometimes it might be having a read about guidelines and backgrounds, doing a bit of a literature review if we've got something that's a slightly more unusual case or something we don't see very often, trying to kind of gather that information that I can then go and chat to the consultant with can be helpful, I think, hopefully. And that helps my learning and helps them as well, because then they've got more information available when making the final decisions about things. I really love teaching as well. I think that's really fun and something I quite enjoy doing alongside kind of medical work when I'm in the hospital. Sometimes when you're on the phone and you're chatting and consulting, it's really helpful and say to the juniors, does that make sense? Like, can I make anything a bit more clear? Because there are things that I've learned over the years that I had no idea about when I started. So hopefully being able to teach a little bit more kind of formally and informally is really helpful. And then again, throughout our training, we're kind of encouraged to look at quality improvement projects and try and see, is there an area we think could improve, something we could do to make a service more efficient, or look for a new kind of intervention that might make life easier for a clinical team. And so that's really useful as well, to kind of constantly build and improve our services to make sure we're doing the best that we can. And with the resources we've got, trying to see what can we do that might make it a bit better or something we could look for in the future.
Yeah, I mean, it's quite similar. We do have obviously our day-to-day work, but we love getting involved in audits, quality improvement, research. So maybe we need to have a think as to what we can do together. We have said this before. Now it's being recorded. It means that
have to do it.
We have to find a way to do it. But also, I just love collaborating with other healthcare professionals outside of pharmacy. I've done it before, and we have such different perspectives, different experiences, different knowledge that actually when we combine it together, forget the patient being in front of us, it works really, really well. And it's also just really fun. So, if you have any ideas, keep in touch. And if you want to help us with guidelines, we've got plenty of work for you.
Definitely.
But thank you so much for taking the time today to have a conversation with me and get to know, for me to get to know you and your journey and all the work that you've been doing over the last few years to get you to this point, which is quite a long time. And I'm just really looking forward to, spending the next few months with you and working together on our, collaborative approach.
Oh, likewise. Thank you so much for inviting me on. And I feel very privileged to be a non-pharmacist and asked to come and talk here. So I am, very excited for all of the collaborative work we can do. It's definitely the way to go, I think.
Awesome. Thanks.
Thank you very much.